Hello, everyone. Welcome back to our surface cleaning and disinfecting showcase. I'm Adam Okada with Beyond Clean. Before we get started with this next presentation, I'd like to call everyone's attention to the features on your screen. All the windows that you see are movable, so feel free to shrink, enlarge, or move them around to make your event experience fit to your preferences. On the lower left, you're going to see a Q&A window. Throughout each presentation, we do encourage you to send in your questions for the speaker to answer during our Q&A session. And in the upper right, you're going to see a resources window where you can find additional resources to download and access that are provided to you by our event sponsor. Having dedicated 34 years of his career to leading the cleaning and disinfection efforts for hospital environmental service teams, J. Darrell Hicks is a nationally recognized subject matter expert in the field of infection prevention and control. He has written and published numerous articles in professional and healthcare-related journals as part of his passion and commitment to providing a cleaner, safer, and healthier healthcare environment. As the author of Infection Prevention for Dummies, Darrell is committed to not only educating professionals in the environmental service field, but also the average person interested in infection prevention. Today, this infection prevention guru is going to explain the challenges of creating and maintaining a safe, clean, and disinfected environment in the OR. He will also outline the important role checklists play in ensuring OR environment is constantly clean and ready for patient use. Get ready to discover how checklists are paving the way for a safer surgical suite environment by reducing the risk of transmitting surgical site infections. So let's get this clean conversation rolling with J. Darrell Hicks.
Thank you, Adam. Good morning, all. It's good to be here, and I'm grateful for the opportunity to meet with you all today and at least discuss this problem of keeping the ORs safe and clean. Adam, I'm not seeing the presentation. I'm sorry. Let's see.
Not a problem. It should be in your live view. Can you see the live view there in the center of your screen? So that's where the presentation is, and you just go ahead and click through those. Yeah.
Okay. Does everybody see that? Clean role in preventing SSIs. We have these learning objectives today to show the human and financial cost of SSIs, examine the possible role that contaminated surfaces play in surgical infections, explain the challenges of creating and maintaining a clean, safe, and disinfected environment in the OR. Recall the meaning of cleaning, disinfecting, processing as they relate to the standards for environmental cleaning. We'll identify the role that checklists play in consistently delivering an environment that is fit for purpose, and we'll define what that fit for purpose is. And then I'm going to challenge you to make use of housekeeping checklist for AORNs for processes of clean professionals. So you're aware of the problems with SSIs. They're the most common and costly HAI in the U.S. SSIs occur in as many as 5% of patients undergoing inpatient surgery. And I'm not sure what the infection rate for those in outpatient procedures is, but we are only counting inpatient surgeries, and that amounts to between 160,000 and 300,000 cases. I know last year was a lower year for surgical inpatient surgery cases, but a normal year, that's what it would be. And it costs hospitals and costs Americans $10 billion for these infections. Personnel and their compliance with aseptic procedures are a critical component in the prevention of surgical wound infections. Where did we go wrong? Well, there are a variety of possible causes of SSIs. I want to focus today on the role that a contaminated environment in the OR plays in contributing to these serious, life-threatening infections. When clean, gloved hands touch surfaces contaminated with pathogens that can live for 58 or more days on dry surfaces, and then into a body cavity, the outcome of the patient and the institution could be disastrous. So there was a survey conducted and asked, what do you consider to be the most important issues facing perioperative nurses? And of those who answered, 63% said surgical site prevention. You see there budget and resources cuts, 55%, compliance with evidence-based practices, 44, inadequate staffing, 43, et cetera, et cetera. But some of the other responses included too much emphasis on turnaround times. And number 2 there was cleaning between cases and terminal cleaning. So it did show up, just not in the high numbers that you see above there, but it is a concern of perioperative nurses. So when it comes to housekeeping requirements, all cases are considered potentially infectious, just like all patients presenting in the ED are all considered potentially infectious. Cleanup between clean and or dirty cases is the same. You should treat all cases as if they're potentially infectious. The patient must be provided a safe and clean environment. Pathogenic organisms are present on environmental surfaces. We know that they're there. We don't know what the linkage is between those pathogens on a surface and outcomes that would not be desirable. We don't know where the SSIs are coming from, but certainly the environment plays some role in that. We just don't know what percent of that 5% that is caused by contaminated environmental surfaces. As I said earlier, some of those pathogens can survive on surfaces for 58 or more days. C. diff can be 5 months. So it is pretty evident that these pathogens can survive on dry surfaces and they need to be eliminated. So pathogens on environmental surfaces are often transferred to other surfaces and possibly the sterile field. Environmental cleaning is the framework and basis for all aseptic practices. Sanitation protocols for cleaning and disinfection are required before, during, and after each procedure. You all know about the during part and the before and the during case, but after the procedure is when we have the best chance of breaking that chain of infection from one person to the next, one patient to the next. We'll address all the before and after each surgical case. So here's a chance for you to do the first survey of this morning, and I'm asking who is responsible for the overall cleanliness of your surgical department. Do you have your own in-house environmental services department? Is it a shared role between your staff and the OR and EVS? Sometimes OR staff does between case cleaning and EVS does the terminal cleaning, so it could be a shared role. Do you use an outside contractor to do terminal cleaning, end of the day cleaning, or some other? So if you will, cast your vote. We'll see there that the greatest number of responses was EVS and OR employees share that role. I don't know if you mean by sharing that when between case cleaning is happening that you've got anesthesia techs doing their part and EVS doing theirs, or it would maybe better defined as OR staff does the between case cleaning, and environmental services comes along in the evening at the end of the day, case day, and does the terminal clean, which is a common occurrence. So let's talk about definitions, because unless we define these terms, then it's whenever I'm defining these terms, I'm trying to get it down to the lowest level of those who are doing the between case cleaning, the end of day cleaning, all those cleaning services of keeping the OR safe. First one is clean. The CDC's definition refers to the removal of dirt and impurities, including germs, from surfaces. Now, when you remove the soil, the dirt from a surface, the organisms, pathogens contained in that dirt are removed at the same time. So when cleaning alone does not kill germs, but by removing germs, it decreases their number and therefore reduces the risk of infection. Doesn't eliminate it, but it does reduce the risk of infection. Disinfecting works by using chemicals to kill germs on surfaces. This process does not necessarily clean dirty surfaces or remove germs. Remember, the cleaning does that, but killing germs remaining on a surface after cleaning further reduces any risk of spreading infection. And here's a new term that I'm introducing to you. You've probably not heard of it, but the term process as used includes cleaning and disinfecting an item or area using a clean microdenier cloth or flat mop as appropriate, and the facility approved EPA registered disinfectant. We don't clean an operating room, we process it. We don't clean a patient's room, we process it. So whenever you use the term clean in your protocols, clean this, clean that, it means different things to different people. But if we use processing, then it has a definition that is easy to follow. It's a combination of those elements of the microdenier cloth or mop and facility approved EPA registered disinfectant. Fitness for purpose. If sanitizing procedures are to be effective, a determination needs to be done regarding not only product efficacy, the efficacy of the disinfectant, but more importantly, whether the process results in what we want to achieve, namely hands, environmental surfaces, fabrics, etc., which are hygienically clean or fit for purpose as sufficient to break the chain of infection. So unless the chain of infection is broken, then we have not achieved fitness for purpose, because the purpose of those surfaces, whether it's hands or surfaces, fabrics, unless we reach that level where they are not of a risk of transmission of disease, then we haven't reached fit for purpose. This is the term that I like in hygienic cleaning, and processing could be used interchangeably, but it refers to any process intended to reduce the number of pathogens on surfaces to an acceptable level target, an acceptable safety target level, which makes it fit for purpose and hygienically clean. Hygienic cleaning alone does not kill germs, but by removing the microorganisms, it decreases their number and therefore the risk of spreading infection. Simple cleaning of the environmental surfaces may be one of our key defenses in the future battle against infectious disease. With the number of antibiotics being developed being near zero, we're running out of antibiotics, and we're getting these multi-drug resistant organisms proliferating throughout our society. And when we get to that point and we don't have an antibiotic, then hygienic cleaning may be the only thing that saves mankind. So I want to talk about checklists. The original checklists were used by pilots and co-pilots, developed to make sure that everything was done and that nothing was overlooked or forgotten. And it was designed to eliminate accidents and incidents because they were having bombers crash back in World War II. As they got more sophisticated, pilots and co-pilots didn't know really how to fly them, and so they developed checklists so that everything that was essential to the mission was checked off by the pilot and co-pilot. Today, it's a new best practice checklist developed specifically for OR processing, are paving the way to a safer operating room environment, especially in those scenarios involving several infection prevention modes of practice. So cleaning isn't the only mode of practice, infection prevention mode of practice. There's all kinds of them going on in the OR, and so it's a multimodal approach to infection prevention, SSI prevention, but there are best practice checklists for the environmental services folks or your staff if they're doing the between case cleaning. Checklists ensure a safer operating room environment. So from an environmental cleaning perspective, processing the OR is a complex set of steps. Often more than one person is performing the room preparation process. EVS may be in the room, the orderly, anesthesia tech, patient care tech, and not everything is cleaned by environmental services. So each person has got their role, and we can make these checklists so that we communicate at the end of that processing of that room, ready for the next case, that there should be red check marks on all of those steps that need to be taken care of to make that room fit for purpose. The checklist builds accountability by asking for the initials of the person who performed the task. The room isn't ready for the next case until the checklist is completed. And I've seen these done on a laminated sheet of paper and with the marking pins so that are erasable, so that the circulating nurse can come in and before the next patient is wheeled into the room, make sure that everyone has done their role in making that room ready. So I have AOR and checklist. The 24-hour idle processing is a 9-step checklist. OR pre-first procedure processing, that's 7 steps. The between procedure processing is 10 steps, and terminal processing is 10 steps as well. So these are checklists, like I said, to ensure that everything that is important has been cleaned by the appropriate staff and that that room is now fit for purpose, hygienically clean, processed. So types of processing, I mentioned OR first, pre-first procedure. First thing in the morning before the surgical supplies are brought into the room, or it could be the 24-hour. 24-hour idle processing would be when, you know, those rooms that especially are used for emergent cases, they don't usually go more than 24 hours without being used, but some of these other rooms may sit for 2 days, 3 days, you know, a holiday weekend, and before that first case, that first procedure, these 7 steps need to be performed in those rooms to make sure that they're ready for that first case. Then you see between case processing, procedures throughout the day, halting the possible transmission of bloodborne pathogens. Terminal cleaning, processing when done properly and in order, return the operating room to a safe, clean, and disinfected space. So here's your next poll. What material is used for cleaning of your OR? disposable single-use mops and cloths, blue OR towels and string or cotton rayon mops, microfiber wipers and mops, string cotton rayon mops and retired terry cloth washcloths or towels, pre-moistened disinfectant, saturated wipers, some combination of all the above, or I don't know. Great. I like to see this. Microfiber wipers and mops are laundered each day. So we're going to talk about that. Some combination of the above comes in second there, and I understand that you know, these pre-moistened wipes have gotten traction, and one caveat on this is that, you know, these are all being used. And it's important that you understand, you know, where those things are stored at the end of the day, and that they are getting processed in the laundry as they should be, so that they're safe for use in the OR. So we need to talk about soil removal, because I think that this is one of the areas that we miss in this whole role of returning a surface to a fit for purpose. And that is soil removal, because washing or scrubbing a surface physically removes soil and organic material such as blood and potentially infectious material. As the soil, or we can call it a bioload, is removed from a surface, most of the pathogens that live and reproduce in the soil are removed with it. Think about soil, this bioload, as being food for bacteria. And they need to feed in order to stay alive. And so if we remove their food source through a microdenier product, ultra-denier microfiber, and just soap and water, that surface is probably 99.9%, with the soil removed, is 99.9% free of germs, pathogens. The guiding principle is always to remove germs if possible rather than kill them, and then when necessary use the least amount of the mildest chemical or other product that will do the job, because stronger often means more toxic to people and the environment. So for years we have used disinfectants, these toxic corrosive disinfectants, to do the job of killing the little boogers when we ought to be removing them. And if we remove them, then it gives the disinfectant a much better chance to do its job. But if it's fighting soil and all this buildup, biofilm and what have you on surfaces, then the disinfectant can't reach the surface and make it fit for purpose. And not all microfibers create equal. I was at local big box store, and here's 100 microfiber towels for $15 versus the one on the right that is one of those microdenier or ultra denier microfiber cloths, and it might be $1.50 each. But this is more than just a delivery tool. You know, when we think of this rag, you know, we call them rags. When we think of that rag, we think about it delivering disinfectants to a surface. That's all it does, is deliver the disinfectant. But when you can remove 99% of the soil from a surface with just that rag on the right and water, then and it can last for 200 laundry cycles, and the one on the left can last maybe 5 or 10 before it's ineffective. So choose wisely when you're looking at your microfiber products. But whenever I talk about laundry cycles, think about spores collected in that cloth on the right, which is capable of collecting spores. So think about C. diff. Think about things such as Candida auris, which is a fungus, and some of your disinfectants that you're using may not be sporicidal, they may not be fungicidal. So think about doing a better job of soil removal. So do we use detergent or disinfectant? Use a detergent before using a disinfectant to make sure all soil and dirt are removed, even if equipment is not visibly dirty. It's really a two-step process. One is to remove the soil. Think about washing your hands. We have running water, we use soap, and we use friction. We work that soap into our skin of our hands. We do the backs of our hands, between fingers, all that, and then we rinse under clear water, and then we dry with a towel. And that is considered hand hygiene. But then whenever we get to surfaces, we think that we can just spray a disinfectant and wipe it, and that's doing the same thing. Even if you have a one-step combined detergent disinfectant, it still should be a two-step process. You wipe the first time, it removes the soil, and then the second time you can use the same one-step product and disinfect. But if you can remove 99.9% with just that green microfiber and water, then there isn't much soil left for the disinfectant to finish the preparation of that surface. Damp dusting. As you know, dust in ORs is the vehicle that pathogens travel around on. That's why we try to control dust in the OR. We have to have a good ventilation system, and that those filters need to be cleaned on a scheduled basis so that we provide fresh, clean air into the OR at the appropriate humidity and temperatures. But damp dust first thing in the morning before additional items or equipment are brought into the room. Damp dust from top to bottom. Why damp dust? Removes dust from these horizontal surfaces that the germs and pathogens travel on. So removing those dust particles is key. What should be processed first? We do it from top to bottom, low soil to highly soiled areas. So the most contaminated area of the room is that table and 6 feet around it and above it. But we do it in a clockwise or counterclockwise. Processing may be performed when used along with clean to dirty, top to bottom cleaning methods. This isn't a poll question, but I'm just asking you, with the expectation that we have 10 minutes between cases, can this room be turned over in 10 minutes? And I maintain that it can't, and this is probably an emergency case that was brought in, but those rooms are going to take a lot longer to process. So what must be processed? In the OR procedural room, anesthesia machine and carts, equipment booms, IV poles, pumps, patient monitors. So who's responsible for processing this chaos? It's not housekeeping's responsibility. You can see all those cables, cords, tubing, all that needs to be up off of the floor. And you need to manage that much better. But I'm not saying that it can't be done, but you need to plan for that stuff to be off the floor so that the floor can be processed appropriately, and all that stuff that may be blood contaminated, who knows? If those aren't disposable cords, then what's your plan for processing them? Because it's not necessarily housekeeping's job. The anesthesia cart is not housekeeping's job. Suction devices, the anesthesia machine, all those need to be processed by someone other than environmental services, unless they're your staff, and then they could be a combination of nurses and techs and whatever. But there you see some of these tables. There's a lot of stainless steel in the OR, and that makes for quick wipe down, but also makes things more visible. So the terminal processing, we move the equipment around the room to clean the floor underneath. That's why those cords and cables are important to be up off the floor. Process the chairs, stools, step stools. All those have wheels on them, as well as kick buckets, but the wheels on everything needs to be clean and sutures removed. And you need to really pay attention to these sutures that get wrapped around the axle of wheels, and those need to be routinely taken out somewhere and all that stuff cleaned off of them, because cleaning the wheels doesn't do anything if all the sutures remain on those wheels. We have to process linen receptacles, empty regular and biohazard trash, and empty soil linen. So terminal processing is overhead procedure lights, mobile and fixed equipment. Again, a lot of that is not environmental services responsibility. And nursing needs to work with EVS or whoever's doing the terminal cleaning and identify those items that are not EVS's role, and you put a different color tape on those objects so that the EVS person coming in to work at the end of the day knows exactly what they have to process, and the others, someone else is going to be responsible for. And you can use color coding, whether it's anesthesia that does that, your orderlies, whoever it is. You need to identify those and make sure that those are getting processed as they should be. And there you see the other things that aren't necessarily EVS's job to process. The OR bed and its attachments, a lot of times, wherever the last case was isn't going to be the first case of the next day. So it's good that EVS knows whenever they process that bed and all of its attachments and positioning devices and transfer devices, reusable patient safety straps, all that stuff should be processed by the EVS people doing the terminal cleaning. But anyway, all those things need to be made sure that they are free of cracks and tears in some of the vinyl on those positioning devices. And the OR bed itself cannot have rips, tears, anything presenting an opportunity for blood and body fluids to get into the foam substrate. So we need to be inspecting those and make sure that they're taken out of service if they do have those opportunities for or risk management opportunities. So here we get pictures, and what I wanted to say is that, wherever the last case of the day was, the equipment in that room may not be what the first case of the next day needs to be. So if you want EVS to do that, then as they terminally clean the room, then they can set it up for the first case of the next day with the right equipment. Floor processing, again, we remove soil and debris, disinfect floor surfaces, beginning at the edge of the room first, moving around the room toward the center of the room. Center of the room is where most patient care happens and is likely to be much heavier soil load than the outer edges of the room. And then there's scheduled processing. Not all areas in the OR and procedural areas are cleaned daily. Each facility will decide how frequently these areas should be cleaned, whether it's weekly, monthly, or quarterly. And then you need to maintain a record of all scheduled cleaning. Like machine scrubbing the operating rooms, whether you want that done nightly. Machine scrubbing them is, a brush. It could be a counter-rotating brush or a cylindrical brush and disinfectant. But, sometimes you need that to break up the soil on a surface. It's just the difference between taking a rag and wiping the floor versus, getting a scrub brush and cleaning the floor. So those things will be done on some sort of a schedule, but whatever your process is, someone needs to be keeping records of that, and you need to be checking it to ensure that we are meeting those targets. Some schedule processing could be clean and soiled storage areas, corridors, elevators, environmental service closets, shelves and storage bins, stairwells, and sterile storage areas. There you see scrub sinks, walls, ceilings, privacy curtains, pneumatic tubes, carriers, lounges, workstations. These don't need to be processed, on the same. Think about the fit for purpose of the lounge versus, the OR, the heart room. Coordinated processing. Cleaning of the following equipment will need to be done along with the facility maintenance. The eye wash stations, ice machines, refrigerators, sterilizers, ventilation ducts. Routine maintenance of these items is necessary. Equipment must be cleaned before bringing patients in for care. Competency assessments need to be done on each person responsible for processing the surgical or procedure suite's environmental surfaces and equipment, and they must be properly trained. The person who is responsible for those items that aren't housekeeping's to do, they need to have the same competency assessment as the EVS person. Even if an outside company does the cleaning of the OR suite or procedural rooms, they must be trained, and the company must provide the facility with a record of that training. And here's what I'm advocating for, is that we need to start certifying these environmental services technicians. The time has come to do that. Infection prevention will only become a reality when this person, the CEST, is properly regarded by your staff and by other professionals, educated and equipped. The CEST must be well trained in their job role, equipped with the necessary tools to clean, sanitize, or disinfect, allotted the time to do the necessary task, like that turnover in that room with the blood all over. There needs to be a lot of time to do all those necessary tasks of making that room fit for purpose. We need to be provided with the tools to enable scientific measurement. If we can't measure it, we can't improve it. So we need to be measuring. Educated about the prevention and transmission of disease. Sometimes these people are stuffing hamburgers in a bag in the drive-through 2 weeks ago, and now they're coming to work in the hospital environment, and what has prepared them to start cleaning your heart room? You have to have a level of education. First of all, you have to know the whys of cleaning, not just the how-tos. But anyway, I think that we need to start certifying these folks so that if they're working in your OR providing these essential tasks of cleaning and disinfecting, making the OR safe, they ought to be certified and properly compensated for that. So here's our last survey question. You've seen and probably used this pain intensity scale with patients. So it's time for you to please rate the clean and raised status of your OR suite or surgery center. Just click on the blue box and enter number 1 to 10. Here it is. Okay. 1 to 10. Remember the scale was, well, 10 was the worst possible pain. And we have very few 10s, a few 9s. I'd say that the middle of the pack seems to be needing help or feeling pretty confident. Very few are saying that, you know, it's a 1. But so hopefully what we have talked about here today, and I'm still available for asking or answering your questions, but hopefully what you've learned today can change how you feel about the readiness of your OR for patient care. So with that, Adam, do we have some questions?
Yes, we do have quite a few questions from the group. A lot of very nice compliments coming your way, as well as about the nice and clear presentation that you gave. So very excellent job, Daryl, on your part. I do have a question here about soft surface technology. Soft surface technology is advancing with innovations such as PneumaPure sealed and filtered OR pads. Do you see value in using this technology for soft surfaces in the OR and beyond? And then you know what, there's a second part. I'll ask you the second part next. So soft surface technology, I'll give you that one first.
Soft surfaces, I believe, is one of the greatest challenges that you have in the OR, because soft surfaces cannot truly be disinfected. I don't care if you have a vinyl cover on it. Soft surfaces, there's no disinfectant that has a soft surface disinfectant claim. They have a sanitizing claim, and the difference between sanitizing and disinfecting, you know the difference in sterile processing, what the difference between sanitized and disinfected is. And so we cannot disinfect those soft surfaces. All those vinyl covered stools, positioning, pillows, all that stuff cannot be disinfected. At best, it can be sanitized. But then there's a quick rebound. You know, if it sits idle for 24 hours, 36, 48 hours, if you tested that surface before your first case, you would find a rebound of bacteria, and there's been nothing in that room to provide the bacteria. So it's one of those things that FDA and EPA do not agree on. FDA says that, you know, need to be processed a certain way. EPA registers the disinfectants, and so there's this dichotomy of, you know, following the manufacturer's instructions for use, but a lot of manufacturers will recommend a cleaning with soap and water, rinsing, and then the application of the disinfectant, allow it to sit for the contact time, and then once it reaches its contact time, then you rinse that disinfectant off. Because these sheets that wind up going on the OR table, some of them, a lot of the cotton has been washed out of it, and you have a piece of rayon, and whatever is on that surface now can be entered into a patient's open surgical wound. So you got to think about that table, because it's a very good question, and it's one that is underappreciated as a source of contamination, and it's a real challenge. And There are some companies making a launderable cover for those tables, stretchers. Think about your OR stretchers. They're the same issue there. So that's more of a problem than the hard non-porous surfaces that can be, if processed appropriately, can be hygienically clean.
Excellent. We got a couple of questions about the checklists and the availability of those checklists. Do you know anywhere that they can pull those checklists from, or the AORN checklist perhaps?
You have my contact information right here, and I can provide those to you if you will email me, Daryl@darylhicks.com. I didn't want to put them up here because it would just take a lot of time, but when it says it's a 9-step, process, then I'll define what those steps are. But there's some other tools too, like observations. Should someone be observing the person doing the cleaning and disinfection, and there's some checklists for the observer to make sure that the person doing the processing of equipment or the floors, whatever it is, that you can observe and do a check, an observation checklist as well. And that's key too, that we don't just do competency assessment once a year, but periodically people need to be observed by someone competent to do that, and then sharing that as a training opportunity.
Absolutely.
Yes, that's some checklists.
All right. So yes, if you have Daryl's contact information is there. So if you want to send him an email, there was quite a few questions about the slides as well. If the slides could be made available to people. So if you have any questions or if you want those slides, please email Daryl, and hopefully he'll send those to you. Here's one. Do you have any recommendations for reaching agreement with perioperative leaders on complementary role and responsibilities of EVS professionals and the perioperative team regarding between case and terminal cleaning disinfection of the OR?
Sometimes unions will prohibit that sort of collaboration, but I'm a big proponent of that, and it's the OR team, and the person doing the between case processing needs to be a part of your team and feel a part of the team. But I have no tools for that. I would suggest, that we break down the silos, and, it's all about better patient outcomes and reducing the risk of infections and or death. And SSIs are a high cost to hospitals, so it's incumbent on the perioperative team and the EVS folks to work as one and pick each other up. And I think you'll find we create an air of cooperation and feedback and feeling that we're valued. Then that's all people want, and they will. They'll feed off of that, but I encourage it.
Definitely. And we're all part of the perioperative services team. So anytime you break down those silos of this is my department and this is your department and we're separate, we're actually all part of that same organism. EVS, sterile processing, the OR, infection prevention, all these different departments come together to make those things work. So you're right. Absolutely. That collaboration is really important. And whatever you can do to get those people to understand that, that's obviously helpful. So you got a question about cleaning floors, and can a dust mop be used to clean the floors in the departments, or is damp dusting required for all surfaces?
Damp dusting is required, and I will tell you that there are some tools, and one of them is think about those lobby dustpans that you see housekeeping use. Sometimes it's like in the lobby and they've got a toy broom and they're sweeping debris up into it. Could be pieces of meat, bone, whatever, sweeping up into this dustpan. And when does that dustpan ever get cleaned and disinfected? When does it get processed? So this company has got a disposable bag that fits essentially in the back part of that dustpan. And so that, whenever you sweep into it, it's collecting that into a red bag that then gets put in the red bag waste. But, that we don't use brooms in the OR, but this same company actually has a miniature floor squeegee. And, so that you can move that debris into the dustpan as a first step before you process that floor by disinfecting, the whole process of disinfecting the floor.
Excellent. And that's something I think a lot of people probably don't think about is, how often are we disinfecting these things that are cleaning, the cleaning supplies and things. That's an interesting point. We had a lot of support. I think there were 3 or 4 comments about support for the EVS certification and why don't people do this? That should be definitely something that we do. I had a question here. Are there any courses to have EVS certified? The
AHE has got one for OR folks. And, I think that it is a very good education and training. And I feel like we educate people and we train 4-legged animals. We should be educating people, and AHE has got a pretty good program for that. You can check it out. You really need one person in the hospital that's, goes through, it's called CHEST, C-H-E-S-T, but it's for surgical techs, but that would be you need a trainer. So that could be a senior environmental services person, but then they will take the crew through the certification process. And it's very valuable, it's very detailed, and I would suggest it.
Okay. Got a question here about UV room disinfection. What do you think about UV room between cases when it's possible?
I have mixed feelings about UV and its ability to, you always have the problem of shadows, and it's a line of sight. And, my issues with it is that when we try to use it in our OR, you have all these dedicated electrical outlets in the operating room itself. And there is, my biggest nightmare fear was that one of my employees would go and unplug something and plug in the UV unit and not plug the medical equipment back in. It needs to be recalibrated. They come in for the first case of the day and somebody unplugged it. So I'm not a detractor of UV. I think that there are other technologies that deliver a similar product in a much shorter time, and that's the application of disinfectants with electrostatic sprayers. And there are some companies that have those, and you'll see them being used on airplanes and a lot of places, public spaces. But what electrostatic spraying does is it doesn't work on gravity. Whenever the disinfectant comes out of the spray nozzle, then there's a positive charge put to that particle of disinfectant, and it works like static electricity. It's looking for something to attach to, and will attach to the underneath side of the table that maybe someone didn't wipe with the disinfectant, but it's doing this kind of 360-degree wrap around items. And so I think that there is, because between case cleaning, I don't know if you have enough time, because the room has to be cleaned first, and UV or disinfectants have to be applied to pre-cleaned surfaces. So if you start with a clean surface, like you should with either process, which is the quickest to deliver the room to ready for the next patient, wheels up to wheels down, and it would be electrostatic spraying.
And that, I think, leads right into this question. So what are your feelings on the products that are misted on the surface once the room is done being processed, that has now become a thing with COVID and everything?
Yeah. What was the question? How effective is that? Or
what are your feelings on the products that are the misted on the surfaces?
Well, the products are the disinfectants that are hospital approved, and not all disinfectants have EPA's disinfectant claim or electrostatic claim on them. If you go to EPA's list N, which is for all COVID related disinfectants, and last count there's 560 of them. Of the 560, I would recommend about 5 of them. But you should be looking for one that is able to be applied to, through an electrostatic sprayer, because the question is, not all disinfectants have been tested to be applied electrostatically. You should choose those that have been. And the manufacturer will tell you, but don't just take their word for it. It should be on the product's label or on the product's master label that you can get at EPA. Just do epa.gov disinfectants, and there's different lists. The list K is for all disinfectants that are sporicidal. So if it has a sporicidal C. diff claim, chances are it has a C. auris claim also. But those are the ones that we should be looking for because at that higher level of being sporicidal, it kills not only spores, but everything beneath them, all the way down to the easiest to kill, spores being kind of the pinnacle of the pyramid. So if you can kill that, it kills everything beneath that as well.
Right. And at my last hospital, we actually just went through this with the EPA and label claims, and we thought our, surface cleaning device was good enough for our case cart. So our case cart washer had gone down. We thought our disinfectant would work. And we learned from infection prevention, no, it does not have the cable claim for spores or for COVID or for all these things. Right. So we had to go with a different product. But it's always good to kind of investigate the chemicals that you're using, whatever your area is, and really think about, is this really supposed to be used in the way that I'm using it? Because, we use them on weird things like on case carts. That's another kind of oddball thing that, we don't really think about. If you have a cart washer, that's great. But there are a lot of hospitals out there that don't, and they have to worry about this disinfectant claim on case carts specifically. So always good to investigate those things. This is more of a comment. I don't know if it's a question so much, but this one says, our hospital does not have EVS Clean Central Sterile. They feel it's on the 2 employees in CS to clean. What are your feelings on maybe where to start to help show the importance of terminal cleaning in Central Sterile as well as the decon area?
That is a great missed opportunity to complete that cycle of from clean instruments going into the case to those instruments coming out of the case and going for sterile processing and ready for the next case. So it doesn't make financial sense to not have the people that are best at cleaning and disinfecting of surfaces doing that work and free up the CS people to do their jobs well. And so I would be an advocate for adding, I don't know how big the sterile processing area is. If a person went in to do it, would that be 2 hours worth of work a night, 5 hours? But, see if why you can't make a business case for that and just reducing SSIs. I don't know what your SSI rates are in your hospital, but you can use that to build a business case for maybe we need to do better cleaning and disinfection in the area that these instruments are being processed and made safe, clean, and disinfected.
Yes, absolutely. And I mean, for me, as like a former SPD manager, something that I would probably tell them is that, you know, if you look through the issue manual or AMI guidelines, they all say that environmental services should be coming in to do those cleanings of the surfaces in those areas, floors and all these things. So those are responsibilities. You can go to documentation that shows that those are the responsibilities of EVS, and hopefully that will help you kind of get that conversation started. If you have to, show them this video and show them the recording of this session where we're recommending that EVS actually take over the cleaning of the environment in sterile processing. That is actually what their responsibility is. And SPD, even if your techs are certified, that's not really in their training to do that kind of surface cleaning. So let them focus on what they're good at and let EVS focus on what they're good at.
And then build a certification person for our process for the person doing the cleaning in there, so that you make sure that, you know, all the things we talked about for in the OR should be applicable to cleaning of CS, sterile processing. So, you know, you build those same checklists, the same competencies, all that stuff, because it just makes sense that that you complete the puzzle with the sterile processing side of things, and then where those things are stored too, you know, before they go into the OR. So you need to follow it along each step of the way, and you know, it just makes sense that, you know, you look at the whole process from, you know, dirty instruments from a case, and then follow that all the way through to the open for the next case. And so you make sure that you improve all those steps along the way and ensure the best outcomes.
Absolutely. Complete that cycle, right? That's what we're looking for. So we're out of time. Unfortunately, we just went a minute over, but that's not a problem. Thank you, Daryl, so much for sharing your keen insights on such a critical topic. If you had questions that we weren't able to get to, you can connect with Daryl via email, and I'm sure he will gladly answer them. We are going to have a short 15-minute break before the next session. Thank you again for joining us today, and we'll see you soon for a discussion dedicated to environmental contamination and cleaning. Thank you, everyone.